Imagine this. A parent comes into your office and says, "I'm worried. My child is telling me that they are seeing or hearing things that just don't seem to be there." Concerns like this about potential hallucinations can be unsettling for both parents and clinicians. Often, even the word hallucination immediately conjures fear of a mind gripped by a psychotic state, but contemporary research paints a much more nuanced picture. Over the next 10 minutes or so, we will provide a practical framework and easy to use clinical tools to help you differentiate benign developmental phenomena from true pathology, and then guide your assessment and management of childhood descriptions of these hallucinations. The first and most important takeaway is this: hallucinatory experiences in children are far more common than you might think, and they usually aren't a sign of schizophrenia. Large-scale studies show that up to 17% of children and adolescents report some form of hallucinatory experience. But the latest NIMH estimate for the incidence of childhood schizophrenia was just 0.04%. So in translation, for the vast majority, these experiences are transient and resolve with guidance from a trained clinician. So our clinical paradigm has shifted from a binary psychosis or not model to a continuum that revolves around risk factors for progression and impairment. Let's talk about low-risk paradigms. If a child is not experiencing accompanying voices or auditory hallucinations with their visual experiences, it is unlikely to be a psychotic disorder, and more likely to be one of the following: imaginary companions. Large observational studies show that up to 65% of school-aged children have one, and they're actually associated with positive qualities like creativity and better coping skills. The key differentiator here is volitional control. A child can typically summon and dismiss their vivid imaginary friend at will, sometimes with their friends, and the companion is a source of comfort, not fear. This is in stark contrast to a visual hallucination, which is intrusive, disturbing, often lifelike, but distorted. Also, we have medication side effects, such as stimulants, corticosteroids, anticholinergics like Benadryl, even THC, or especially THC. These tend to be visual hallucinations, and the symptoms rapidly cease with discontinuation. In clinic, we saw a 5-year-old boy because he had recently started seeing spiders everywhere. It turns out he was recently started on Vyvanse for ADHD, and within a couple days of stopping the treatment, the stimulant, all the spiders magically disappeared. This is fairly typical for a story about medication-induced hallucinations. And next, we have epilepsy. Are the events stereotyped, repetitive, and brief, lasting only a minute or two? Is there an aura or a post-ictal state of confusion? Is there an olfactory or smelling component? These all point to specific neurological insults, such as seizures or infections. Then we can also consider migraine with aura, which can cause bizarre visual distortions known as Alice in Wonderland syndrome, where objects tend to appear to change shape and size. Finally, we want to rule out delirium. Any child with an acute onset of hallucinations in the context of high fever or systemic illness needs an immediate medical workup in an emergency setting. If there are no clear, potentially reversible causes or explanations like these, we want to give you several tools to take straightforward, evidence-based steps to ensure that insidious symptoms do not take on a life of their own. If there have been noticeable changes in emotions or behavior, always screen for trauma. There's a powerful link between trauma and the development of parapsychotic symptoms. And no, critically, a child is never too young to remember. If a child, in fact, cannot verbalize what they experienced, it will be harder to resolve. The explicit nature of a child's trauma may not be represented exactly in hallucinations or their behavior. Here's a validated survey for general trauma called the ACE, or Adverse Childhood Experiences Survey, that will be covered in more depth in a following video about trauma's impact on the developing brain. Importantly, trauma does not rule out schizophrenia. In fact, it only increases the risk of developing an independent psychotic disorder, as they are both associated with significant brain inflammation and changes over time. Now, let's go over some accompanying red flag symptoms to look out for that may indicate a child or teen is experiencing a high risk period for psychosis. as opposed to any of the features of PTSD, autism spectrum disorder, or any of the other scenarios mentioned before. There are a wide range of possibilities, but look for a gradual but marked decline in academic and social functioning. Also, disorganized speech using uncharacteristic words, sounds, or repetitions. Paranoia and the emergence of negative symptoms like flat expression or affect, isolating to the room, for example, or a complete lack of motivation. These things are often not subtle, but importantly, the thing to remember is that about 20% of those with these high-risk symptoms do go on to develop a psychotic disorder, typically within the next 2 to 3 years. If you have any suspicion for these red flag symptoms, we recommend using our PRIME risk stratification survey and the administration instructions that we are including as a link. If the PRIME screener is negative, ensure that there is close follow-up over the next 3 years, as progression during this early period tends to occur. On the other hand, if the PRIME screener is positive, refer to therapy and psychiatry. That being said, if there appears to be a significant delay in the patient's ability to get this specialty care, and they meet DSM-5 criteria for schizophrenia, strongly consider initiating medical treatment, because while the symptoms themselves can wax and wane with time, sometimes even with months between psychotic symptoms with a long period of seeming normalcy, the underlying neurological changes beneath the surface are progressive and associated with degeneration of key brain regions. These include the hippocampus for our memory, the amygdala for managing our emotions, the frontal lobe that helps with decision-making, and generalized thinning of the cerebral cortex. This is why kids are so vulnerable to irreversible cognitive changes, particularly early in psychotic disorders. It can be challenging, we know, to approach medication, as there is a laundry list of approved agents for children and adolescents. To name a few: risperidone, quetiapine, olanzapine, aripiprazole, paliperidone. These are the second generations that are commonly seen, as well as some first generations that are less commonly used but still do have the FDA approval, like chlorpromazine or Thorazine. To make matters even more challenging, there is not a current ACAP algorithm for stepwise treatment. However, Frontier and I want to provide an evidence-based approach to treat these early symptoms of psychosis using FDA-approved agents and dosing. The following stepwise approach will also be included in a link, but to be clear, there is no evidence to treat until they meet DSM criteria. So we recommend against using these antipsychotic treatments as a preventative tool, or the use of imaging in that vein. So initially, we think Abilify can be a good place to start, as it can help support co-occurring anxious or depressive symptoms. If this is not tolerated or does not achieve the intended effect, transitioning to olanzapine would provide an alternative with a vastly different pharmacologic profile, similar to clozapine. And believe it or not, large-scale comparison studies actually show this to be one of the best tolerated and continued medications in the class, despite its well-known risk of weight gain and sedation. It also probably doesn't need to be said, but before starting these medications, it is important to review the need to closely watch for metabolic change or unusual movements that would indicate akathisia or tardive dyskinesia. But it doesn't stop with medication. All evidence points to the importance of patient and family involvement in therapy along the way to help promote overall functioning and medication usage. Here are 3 important takeaways. Remember, psychotic disorders tend to involve auditory hallucinations, as opposed to organic or more reversible causes that primarily involve visual hallucinations. Also remember, psychotic disorders are progressive. They are neurodegenerative conditions necessitating early identification and treatment. Like the saying goes with strokes, time is brain. And finally, remember to use validated screening tools to guide consultation, but feel confident in using evidence-based antipsychotic approaches if they meet DSM-5 criteria for schizophrenia. Oh, and don't forget that ever-critical therapeutic component. We have included 2 detailed ACAP guides for more information on schizophrenia and antipsychotic use for further reference. And that's all we have for today. Thanks for joining us.